Hey gang, this is Gonzo Gonzalez with AskDrGonzoAnything.com, and I today have the distinct pleasure of having another one of my friends here, Dr. Scott Ewing from Texas Healthcare Cardiology here in Fort Worth. Scott, how are you?
I'm doing great. How are you doing?
I'm doing really good. Thanks for visiting with me today and agreeing to doing one of the episodes. As I told you, I started this about 2 years ago, and what I'm trying to do is create awareness about cardiovascular disease here in Fort Worth. And I figured that a podcast was a really good way of doing it, and it allowed me to reach individuals like yourself that have a lot of interest in trying to help the Fort Worth community, and have been here for a while. How long have you been in Fort Worth for?
I've been practicing here for 9 years,
Okay.
and before that I was in training and here in Fort Worth, and I'm a local. I'm from faraway Dallas, and I'm just excited to be here, and thank you for having me.
So I thought that we would start by talking a little bit about risk factors associated to valvular heart disease. As you know, a little over a year ago, we started the Fort Worth Valve program, and it's been going great. For those of you listening, Scott is one of the many cardiologists, but clearly one of the key cardiologists that supports the program and assists in developing all the things that we do in the structural heart disease program here in Fort Worth. And so without Scott, we couldn't be doing what we're doing today. So tell me a little bit about risk factors. The public has heard us talk about aneurysms, and Bunny was on the show a couple of weeks ago, and she talked about what a normal echo looks like. So I figured that if you give us an opportunity to sort of explain to us what are risk factors. Are there risk factors for valve disease?
Yes, there are, and it turns out the risk factors are different depending on which valve of the heart that you're talking about. For example, if we're talking about the aortic valve and talking about the aortic valve not opening very well, and we refer to that as stenosis, meaning the valve doesn't open like it should, there are risk factors that are particular to that disease process. For example, with aortic valve stenosis, one of the biggest risk factors is if the valve is defective from birth, meaning you're born with a 2-leaflet valve instead of a usual 3-leaflet valve, and a 2-leaflet valve, we call that a bicuspid aortic valve. And if you have a bicuspid aortic valve, that is a big risk factor for developing aortic valve stenosis by the time you're middle age. Usually between the ages of 30s to 50s, people will develop symptomatic aortic valve stenosis and will have to have that valve fixed.
Scott, how frequent is it in the general population, do you know, that people are born with 2 leaflets instead of 3 in the aortic valve position?
It turns out that about 1 or 2% of the U.S. population are born with a 2-leaflet aortic valve. I do have many of these patients in my practice, and some the valve has started failing in their 30s, and some they're in their 50s, and we're still just watching the valve because it hasn't yet failed. But like I tell my patients, it's probably inevitable that they will develop symptomatic aortic valve disease because of their bicuspid aortic valve, and it'll have to be fixed.
Now, bicuspid aortic valve, and this is a classic teaching, is it associated with any other conditions if you have 2 leaflets?
It can be. It can be associated with narrowing of the aorta. That's called coarctation of the aorta. That's common. We look for that when usually with a CAT scan, and that would be the most common. The other risk factors that, of course, we have to pay attention to, besides the 2-leaflet aortic valve, would be your traditional risk factors that we all think of: smoking, high blood pressure, high cholesterol, diabetes. Rheumatic fever is also a big risk factor for aortic valve stenosis, but luckily in this country that's not a very common disease process because most people in this country just don't have rheumatic fever as a youngster with their strep throat or their scarlet fever. But we do see that a lot in our immigrant population that maybe moved to this country from Mexico or China or India or Southeast Asia or the Middle East, where they didn't necessarily receive the same antibiotic therapy for strep throat when they were youngsters, and then as adults they develop aortic valve stenosis.
So that's actually a really good point. So let me hone in on a couple of the risk factors that you pointed out. So you talked about exposure factors and genetic factors, pretty much,
Yes.
The way that we look at it with regards of acquiring these diseases. Smoking, diabetes, high blood pressure, how does that affect the valve structurally?
A lot of it is through inflammatory disease process and causing thickening of the leaflets and fusing of the leaflets together, and such that the leaflets can't open like they should anymore, and causing narrowing of the opening, and we call that stenosis, of course. What's interesting, and of course I did a little reading before we started talking today, because it never hurts to go back and look at the literature. The studies are very clear in terms of the risk factors for aortic valve stenosis, but the studies are not very clear in terms of if I treat those risk factors, will it keep me from getting aortic valve stenosis? And there's actually not a lot of good literature along those lines. For example, if I have high blood pressure and I treat it with medicine, will that keep me from getting aortic valve stenosis? And there's not a lot of data to say that. And if I quit smoking, will that keep me from getting aortic valve stenosis? There's not a lot of data, again, to say that. So it's a complex disease process. The one thing it is pretty clear, though, if you've got a genetic two-leaflet valve, I hate to say this, but you're kind of doomed. You're gonna need to get that valve fixed sometime in your life, most likely. High likelihood by the time you're, say, age 55.
Okay. So tell me a little bit about when you have valve disease, and I know we're going to talk about the mitral valve in a second. But what's right now the consensus, or I shouldn't say consensus, what's your opinion about people and infections associated to valvular heart disease? Are we, and I know the pendulum has swung, and I know that at one point everybody got antibiotics if they have known valvular heart disease. Then some folks started saying, well, you really don't have to do that. The risk is actually greater of acquiring some infections that are drug resistant. Where are we at in the great scheme of things? What's your practice?
Absolutely. When I was in training, everybody got antibiotics before they had a dental procedure, and everybody got antibiotics before they had a colonoscopy or another GI procedure. And we call that antibiotic prophylaxis because of valvular heart disease. The pendulum has swung the other way, and very, very few of my patients get antibiotic prophylaxis. And typically, we reserve the antibiotics for patients who maybe have had an artificial valve implanted in their body. Then they would get antibiotics. People that have congenital heart disease from birth that hasn't been corrected surgically, they still need antibiotics. But just because you have a murmur, just because you have aortic valve stenosis, for example, or other valvular disease that hasn't been fixed yet, those patients we generally don't give antibiotics, because it turns out that you're more likely to suffer complications from taking the antibiotics than to actually get a heart infection if you don't take the antibiotics.
That's a great point. You've actually, what you've described is beautiful, the fact that the pendulum has swung. I mean,
absolutely, in
the last 20 years, I mean, we're talking a completely different way of managing these patients. And I still think that the jury's out, and a lot of us still try to treat them based on what the data or the suggestions are from the guidelines out there. Okay, let's switch gears and let's talk about a different valve now. Let's talk about the mitral valve. And as I usually point out to patients who come to the Fort Worth mitral valve program, the mitral valve is basically a valve that resides on the left side of your heart, and it divides the upper and the lower chamber of the heart on the left side. And basically it's the gateway to the ventricle. That basically fills up the heart. The ventricle is the place of the heart that basically fills up with blood, and it gets ready to eject it or push it out to the rest of the body so it gets oxygen. So tell me a little bit about risk factors associated to mitral valve disease.
Well, there are two major areas of the mitral valve dysfunction that we think about. There is mitral valve stenosis, which is just like when we were talking about the aortic valve, where the valve doesn't open like it should, and the opening or the orifice is much smaller than you want it to be in order for the blood to pass through there freely. And then there's the valve opens okay, but then doesn't necessarily close okay, and letting blood leak backwards. And we call that mitral valve regurgitation. Regurgitation meaning leakage of the blood in a backwards direction. And the risk factors are similar but different. Mitral valve stenosis is again, a pretty uncommon disease in this country, except for people that have had rheumatic fever as a child or as a young adult. It turns out that can be a major player in mitral valve stenosis, and we do see that occasionally, especially in our older patients who maybe didn't take antibiotics when they were young, or our immigrant population from for example, Mexico or India or wherever. It also turns out it's a little more common in older patients. It stinks to get old, that's for sure. And then for reasons that are just not clear, it's a little more common in our female patients than our male patients.
Okay.
The incidence goes up a little bit in the female population. But again, it's not really clear why. Again, with rheumatic fever not being very common, mitral valve stenosis just isn't that common in this country. So let's turn our attention then to the other kind of mitral valve disease, mitral valve regurgitation. That has many, many risk factors and many, many causes, with rheumatic fever being a cause, but again, uncommon. The most common cause of mitral valve regurgitation is a primary reason would be what's called myxomatous degeneration of the valve and the valve structure.
And that's one of the most common ones that we see at the mitral valve program here in Fort Worth.
Absolutely, and it's kind of difficult to understand what myxomatous changes are, but it refers to kind of the structural tissue and the structural connective tissue of the valve is defective and fails due to the passage of time and the a little bit of bad luck, so to speak. And
there's also there's glycogen deposits that we see in myxomatous valve disease, which I don't know still if it's actually long-term injury,
right,
or has predilection to be deposited there, right? Because when
Absolutely.
we see these pathology samples here in the program, it's the classic. Oh yeah, they've got these glycogen deposits too,
Sure.
and they're long and distorted and everything.
But I'm probably like everybody that's listening, is like, what the heck is glycogen deposits?
Right, right.
It's that stuff that collects on valves and it causes problems, and the end result is that the leaflets become longer and billowy like a sail that's flapping in the wind, and some of the parachute cords that hold the valve from moving too far, they stretch and sometimes even break, and that can allow the valve to develop what's called mitral valve prolapse. Mitral valve prolapse is a big cause of mitral regurgitation in these myxomatous valves, and certainly is a big player. There are other primary reasons, whether it be endocarditis, which is an infection in the heart. There's some obscure medicines that can cause mitral regurgitation. These are the issues that really just affect the valve, but maybe the rest of the heart's doing okay, and we think of these as primary causes of mitral valve regurgitation, with myxomatous changes and mitral valve prolapse being the big player here. Then we have your secondary causes of mitral valve regurgitation, and that's where the rest of the heart maybe has some issues. For example, let's say you've had coronary artery disease and maybe a blockage and a previous heart attack, and because now the heart structure has changed from the previous heart attack, you can then develop mitral regurgitation. Sometimes the heart gets larger as the heart gets sicker, and the enlargement or dilation of the heart certainly can cause mitral valve regurgitation. And sometimes it needs to be fixed, and the fix can require surgery, just like any other valve may require surgery to get it fixed.
But for the most part, you guys can manage that medically. I mean, the majority of people that have mitral regurgitation that come into the office, generally you can manage it medically.
Most of my patients have what we call mild or moderate mitral regurgitation, and the treatment of choice is medical, not surgical. And that means that they can live with that valve disease for many, many years, including decades. A lot of my patients in their 70s and 80s, they have mild mitral regurgitation, and it's just, I just tell them it's just there, don't worry about it. Let's just treat you for high blood pressure and high cholesterol and stop your dang smoking and that kind of thing. And
the dang smoking. So Scott, that's a really good summary. So if you had to summarize for a patient or family member that has valvular heart disease, what were the key takeaway points from this conversation?
The key takeaway points is that you have to be somewhat of a friend with your cardiologist. He needs to do an ultrasound or an echocardiogram of your heart every so often. And if you've got mild disease, maybe every few years. If you've got severe disease, maybe every 6 months or 12 months, you need an echocardiogram so that it can be followed, because once it gets worse or bad enough, then it needs to be fixed.
Perfect, Scott. Well, listen, thank you so much for taking time of your busy schedule. It was really informative. See you next week, guys, here at the Ask Dr. Gonzo podcast, and thanks for listening.
Thank you.